there's something I really want to focus on, and that's the basics of spinal cord injury. I think at every level of your training, you'll see it, despite what specialty you're in. And we need to be intelligent about how we articulate what we see and what's going on deeper than the surface. The facts and figures state the following with regards to relevance and epidemiology. It touches a lot of people. Annually, there's about 250,000 to 500,000 individuals that are diagnosed with new injury. That's 2 to 3 million people worldwide living with spinal cord related disability. That's pretty staggering. In the US and Canada alone, most of that is tied to motor vehicle injuries or collisions because of the high mechanism of injury, such as what you would see producing the MRI to the right here. In developing countries, sadly, a lot of these are tied to blunt force trauma or violence. Despite whatever country, there's a very heavy male predominance greater than female. So those kinds of things have stayed relatively stable, the mechanisms of injury, who's affected. There's kind of a sad toll to it when you think about the impact on the youth across the world. There's a psychological impact. Imagine being fine one day and the next day you're unable to walk or move your hands, possibly breathe on your own, protect your own bowel bladder function, and whatever else comes in the next year that may end your life. There's a huge psychological impact and comorbid disease in that regard. Many people with spinal cord injuries will have premature deaths because of the comorbidities. They're about 2 to 5 times more likely to succumb to any of the related comorbidities in the developing world relative to the US or the North American countries where we have a higher level of available support care. And that's not to mention the economic burden. Each one of these people who are mostly young, healthy, robust members of the workforce are now representative of lost productivity. And on top of that, they generate healthcare costs every day, some of which they may not have the ability to pay back or resources to support their own care. So we know what it is when we see it, but how do you communicate that in an effective way, let alone document it? The American Spinal Injury Association, or the ASIA Foundation, is what we go by. Note that you can't do this right up front because of a couple things we'll get into, but there's a very clear, methodical way in whatever language you speak to do this. This is a page from the website itself where the worksheet is available. It's free. It's a 2-page worksheet. You probably are familiar with the page 1, where it's the right-left documentation with the dermatomes. But know that you can download it in Spanish, French, Greek, Japanese, or probably other languages I'm not aware of. So let's look at that a little bit deeper. When you first look at the sheet, it can be a little overwhelming, and it looks like it's going to take an hour or 2 hours. But it's really what you guys do every day when you assess somebody. You think about their alertness, their mental status when you're thinking about cranial nerve and mental faculties. But dermatome by dermatome, you're assessing sensation, light touch, temperature, pinprick, reception, as well as motor function. There's specific, eloquent nerve roots that think of per level. For example, C5 elbow flexors, C6 wrist extensors, C7 elbow extensors, C8 finger flexion, T1 finger abduction. That'll tell you a lot. But when that's a kind of hazy picture, what do? There's something for that too. In the lower extremity, eloquent things being L2 for hip flexion, L3 for knee extension, L4 ankle dorsiflexor, L5 for long toe extensors or EHL, and S1 for ankle plantar flexion. Then once you get through that whole rubric of all these boxes to fill out, you have to say, what is the injury, complete, incomplete, what is the level, and then a global ASIA impairment scale rating. And is there a zone of partial preservation? This is page 2, also very wordy, a lot to get through, but we're going to do it. So go step by step like you do with anything. Step 1, determine the sensory level on the right and left side. This can most be done with the light touch modality, where you simply touch the patient in the discrete dermatome to say, are they able to feel that? If it's discrepant, you can use pinprick or temperature to help you figure it out. The sensory level will be the most caudal intact dermatome for both pinprick and light touch sensation. Step 2, you determine the motor level for right and left side. Each of these is right and left side. That is defined by the lowest key muscle function that has at least a grade 3 out of the motor scale that you should know by now, but we'll go through that too. and you need to provide that the key muscle functions represented by that segment are intact. You're doing this in a supine position. Note that in regions where there's no myotome to test, the motor level is kind of presumed to be the same as the sensory level. So that's kind of a surrogate marker there. Step 3, you add 1 and 2 to define your neurologic level of injury. So that refers again to the most caudal segment of the cord with intact sensation and at least anti-gravity 3 out of 5 strength for muscle function, provided there's normal sensory motor function rostrally to that segment respectively. Step 4, the complete thing. Most people kind of flub this a little bit. The real definition is absence or preservation of sacral sparing. So if there's voluntary anal contraction, no. And all S4 sensory scores are 0, and deep anal pressure, no, that is a complete injury. If there's any preservation of those things, anal contraction, sensory scores S4 through 5, deep anal pressure, the injury is incomplete. So you put all that together and you get to the A, B, C's, D's. So if the injury is complete, it's ASIA A. If they're a normal human, that's ASIA E. In between there's kind of a stepwise algorithm. If the injury is motor complete, ASIA B. If no, you work through it to see what is left. If at least half or more of the key muscle groups below the neurologic injury are graded 3 or better, ASIA D. If not, ASIA C. So again, intact ASIA E, complete injury ASIA A, then you work through motor and work through sensory to get the B, C, D. Regarding the zone of potential or partial preservation, ZPP, they're only used in injuries where there's absent motor or sensory function. So all the modalities there for sensory, and the lowest sacral segments S4 to 5. And these refer to the dermatomes and myotomes with caudal to the sensory motor levels that remain partially innervated. So that's a little tricky, but most times you can figure out the ASIA classification without going that far into the weeds. Muscle function grading is a pet peeve of mine. So we mostly reported through 0 through 5. People get kind of mixed up with the 4s. 0 is total paralysis. 1 is a palpable or visible contraction, something you could see or barely feel. 2 is active movement with full range of motion with gravity eliminated. 3 being the key dividing line with active movement against gravity. The 4s, as you know, we grade 4 minus, 4, 4 plus. Active movement, full range of motion against gravity, and moderate resistance. Not full, moderate, of which there's shades of gray that you can kind of work out for what you feel is appropriate for 4 minus, barely anti-gravity, 4 robustly anti-gravity, 4 plus, just about full strength, but not quite. Note that a robust young 26-year-old man is not the same as an 86-year-old frail grandma with regards to a 5. So you have to be variable in your kind of sensitivity depending on who you're examining. NT is important to designate. Many of the people with spinal cord injury will have concomitant injuries and hence have things that you cannot test due to mobilization or severe pain, or perhaps even limb amputation if they're severely affected. People with other injuries such as previous strokes may even have contracture. So that's something that cannot be tested in a muscle grading fashion according to the 0 to 5 scale. Sensory grading on the ASIA rubric is 0 absent, 1 altered, 2 normal, or again, NT not testable. So a little bit ago, we talked about root levels, and sometimes it's kind of dicey. So in addition to those that we listed on the first worksheet, here are some additional muscles you can think of or movements you can think of to help classify per root level. At C5, you're thinking shoulder and elbow. So you're looking at flexion, extension, abduction, adduction, internal, external rotation of the shoulder. So gross, big movements you should be able to see with the C5 level being intact. Also elbow supination. Dropping to C6, you want to see elbow pronation and wrist flexion. Going to C7, you need to see finger flexion at the proximal joint and extension. Also thumb flexion, extension, abduction in the plane of the thumb. Going to C8, more intrinsics, so thinking flexion at the MCP joint and thumb opposition, adduction and abduction perpendicular to the palm. and then T1 being the last of which you would get from the brachial plexus with abduction of the index finger. Dropping to the lumbosacral plexus roots, L2 being hip adduction, coming to the midline, L3 being external rotation of the hips. L4 has a lot going on, as you'd imagine, with hip extension, abduction, internal rotation, and knee flexion. It also is a very important ankle inversion and eversion tool. Lastly, getting to the toes at the metatarsophalangeal, interphalangeal extensions. L5, everybody should know, hopefully, with the hallux and toe, DIP, PAB flexion, and abduction. And lastly, S1, most people don't have a trouble with the plantar flexion, but at least if you need an additional muscle, you can see hallux adduction or coming towards the midline. So that's the middle piece that you really get to at the end. And a lot of our PM&R colleagues help us with the Asian Pyramid Scale rating. Again, I stress that you should not be doing this necessarily in the first 24 hours because things can change. Why? Because of primary and secondary spinal cord injury. Primary injury is what happens at the initial time of impact. There's a mechanism that someone got hurt. Something's compressed, lacerated, distracted, translated with regard to the spinal column, or sheared. There are hallmarks, obviously in clinical exam, but radiographically, with local hemorrhage or disruption of vasculature, edema, which shifts the local neurons in glia and deprives the tissue of glucose. Note that edema can be cytotoxic and vasogenic. And lastly, ischemia or deprivation of oxygen. Stark contrast to secondary injury, which is a delayed damage. It's not right at when the trauma occurs, it's sometime after, minutes to hours. It's the delayed damage and death due to the adjacent cells surviving the original trauma. And there's a really big cascade of biochemical events that we want to touch on today. Secondary injury itself is phasic, with acute, subacute, and chronic phases being defined. So you're looking at the patient, they're in their process of transformation from primary to secondary injury. What's going on at the cellular level? This is a picture of obviously a neuron in the acute and chronic stages of injury. So something happens to them. There's a point of impact or injury where the gray and white matter begin to degrade. You'll recall that white matter is instituted by myelin and nodes of Ranvier that kind of make axons and saltatory neuronal conduction. If that pathway is broken, you have a primary injury. That could be, again, with the mechanisms we discussed. At some point later, that will stabilize out by a variety of things that we'll get into. And there'll be likely some sort of scar or myelomalacia that has happened on the aftermath, visible by imaging in a delayed fashion. So the acute phase happens immediately. This is the shock stuff. Spinal shock is not neurogenic shock, very different pathophysiologic mechanisms. Spinal shock happens right away, and it's sensory deficits, flaccid paralysis, absence of deep 10 reflexes, absence of somatic reflexes, thermoregulatory dysfunction below the level of injury, discrete level, and the absence of the bulbocavernosus reflex. When the bulbocavernosus reflex returns, that indicates that spinal shock has ceased. Neurogenic shock is, again, different. It's arterial hypotension, bradycardia hypothermia, and that's due to the unopposed parasympathetic tone. In the spinal cord injury, there's a severance of the sympathetic innervation. Going more into the acute phase, there's vascular dysfunction. That is local microcirculation disruption of the capillaries and venules with downstream effects. There's hemorrhage within the gray matter that begets necrosis and ultimately myelomalacia. It couples with systemic hypotension in the shock. So the local microcirculation can't perfuse if the greater circulation is not perfusing. And on top of that, there can be microcirculation vasospasm, of which the mechanisms are still being studied. But basically, they're vasoactive amines that kick into high gear and impair the microcirculation. Altogether, this begets endothelial vascular damage with accumulation of oxygen-free radicals and toxic cell metabolites. So injury begets more injury, and that's a secondary effect. On the cellular level, there's membrane and ionic dysfunction. There's disrupted integrity of the membrane, and that yields permeability to ions, the big player being calcium. With disruption of calcium homeostasis, the whole cell begins to involute on itself. So the first thing that happens is calcium moves into the intracellular space. And that kicks off proteases and other enzymes that begin to eat the cell from the inside. For example, in the diagram here, extracellular calcium influx comes in. It can release excitatory neurotransmitters like glutamate. And then from there, you get activation of the endoplasmic reticulum and certain secondary signaling molecules like IP3 and ryanodine receptors. The mitochondria get very upset about this situation, and their function is disrupted, upregulating the production of reactive oxygen species and beginning more calcium influx, and then the mechanisms of apoptosis. Apoptosis through activation of the cytoskeletal destruction and more free radical generation. And once that happens, the cells can literally just lyse, releasing those mediators to the nearby cells and beginning more of a cascade of destruction. So with the membrane and ion dysfunction, there's other players, calcium being the big one, but potassium and sodium have a role as well. In the potassium homeostasis disruption, there's a local compression-mediated conduction block. This also can be stretch-mediated, where the nodes separate some and you can expose the potassium ion channels at these nodes and then hence no longer conduct signal. Similarly, sodium. The AMPA receptor mediated sodium channels are at the axons. So if you have an intracellular accumulation of sodium, you get edema, acidosis, more calcium influx, and then the sodium-calcium exchanger becomes completely altered and the neurons cannot conduct an action potential. This diagram here kind of tries to harp on that point, where you go from a very regulated structure in part A of the figure, where you have specific juxtaparanoids, nodes, and the nodes themselves with very important membrane receptors for potassium and sodium that ultimately become completely dysregulated, and then you lose the myelin integrity on top of that. Getting back to the glutamate thing. So glutamate is an excitatory neurotransmitter. It's stored at the axon terminals, and it's released to the synapse based on calcium influx. Then it's captured by the surrounding astrocytes and transferred back in a normal situation. With injury, excessive release of glutamate happens on an intracellular level and extracellularly. On top of that, there's impaired uptake because the cells that normally would do that job are unable to do so. And hence more calcium influx and so forth through the vicious cycle of apoptosis and cell necrosis. Again, to emphasize what's happening on a subcellular level, glutamate will bind to the secondary signaling molecules via the endoplasmic reticulum and upregulate calcium expression, and the mitochondrial permeability transition port activates as well, letting all the reactive oxygen species out to wreak havoc. So that's the acute phase of secondary injury. Moving to subacute, that's the weeks to month timeline from the injury. That's more of where the free radicals come into play. They're both reactive oxygen species and reactive nitrogen species. Normally, there's antioxidants and antioxidative enzymes that can balance the level of these necessary components that need to be there. In spinal cord injury, both of these, the antioxidants and the antioxidative enzymes, fall. So you get more mitochondrial dysfunction, and there can be direct DNA damage and damage to the intracellular proteins. And then more damage to organelles, the cytoskeleton, and hence apoptosis. On top of that, the reactive oxygen species attack the membranes of the cells themselves. This is called lipid peroxidation. So the polyunsaturated fatty acids, which there's a high concentration of in the CNS, begin to break down as the things from the intracellular space well up and eat them from the inside. So with the unsaturated fatty acids breaking down, you get lipid alkyl radicals that attack the cell membrane, and it just keeps going from there. So in the same way, even if there was a small micro injury to an index cell, it can propagate to the neighboring cells. And then there's more mediated death. And the body has to figure out a way to adapt to that, which we'll talk about in a second. So we have this thing called the immune system, and there's different cellular players about that. The big player in spinal cord injury are the neutrophils. They're seeing perihemorrhage in an average of 3 to 6 hours in animal models, and they peak around 24 hours out. Their job is to prevent further injury by reining in what is being lysed from each of the cells and removing cellular debris. They too can release reactive oxygen species to do the job, and they also release cytokines, hypochlorous acid, and proteinases. Inhibition of neutrophil adhesion to the endothelial cell surface can reduce the severity of spinal cord injury. Think about that for a second. That's the whole reason why they went down the steroid pathway and the Bracken protocols to see if we could reduce secondary spinal cord injury, which is beyond the scope of today's discussion, but I'll point you in a direction to read more about that. Also in the immune-associated neurotoxicity phase, there's activation of the microglia. So the microglia, they're there to kind of protect the neurons. They live there, but they can also be recruited from the circulation. And with recruitment of monocytes, they'll differentiate into macrophages to do more of that job. They're the cell type that predominates about 5 to 10 days after injury and will persist for months thereafter. They explore the pro-inflammatory mediators IL-1, IL-6, and TNF locally. Now, keep in mind that there's a lot of them. The sheer quantity of macrophages present can be the basis of a mass effect, much like a benign tumor, and in and of itself propagate more injury. There are ongoing efforts to understand the subsets of macrophages present, as well as their behavior based on where they originate from, be it bloodborne or resident in nature. And these cells are the pathogenesis of glial scarring. Reactive gliosis is the last phase of secondary injury, the chronic phase. Its true intent of the body is to contain the injury from all the cascading damage. There's speculation about, well, what can it do in a positive light? There's got to be more positive than negative of the actual scarring that happens. So initially, the mature astrocytes will elongate their processes, intermingle, and surround the core lesion that is the spinal cord injury. And it's meant to limit the spread of the inflammatory cells that we spoke about. It also protects the lesion size from increasing and further neuronal loss. Now, by being there, it's in the way. It can prevent axonal regeneration or bridging of the scaffold, but it can serve that same purpose. It's kind of a dual-edged sword. So with increased astrocytes, the extracellular matrix increases too. And this can be a literal block between axon propagation, where some molecules are repelling axonal growth. They also provide growth factors, and they can restore the blood-spinal cord barrier that needs to be intact to prevent any other monocytes from infiltrating from the bloodstream. And they serve to uptake the excess glutamate that's floating freely from all the lysed cells. So that's a lot. And I know you're still probably questioning, what about steroids? Note that in 2002, there was a position statement of the guidelines of the CNS, or AANS, to say that they supported the use of spinal cord injury steroid acute protocols. In 2012, that support ceased and the paradigm shifted based on what they were seeing based on the Nexus 1, 2, and 3 trials. For a quick summary of that, this is a part of what I published back in 2019 for the evidence against the use of spinal cord injury protocols for steroids. It was a 2-part series on the AANS Neurosurgeon website that I'd be happy to share with anybody with additional questions. So I know that was a lot. It was very fast. Here are some references that are also available on that website that I just shared. And I'd be happy to take any questions.
I wonder, in terms of clinical practice and with the acute, subacute injury, what are there's been some work in treating spinal cord injury like a brain injury and trying to increase spinal perfusion. You sort of went over a lot of the pathophysiology, which is really key, but translating that into practice, where is that work at, and what do you think about like doing these lumbar drain for spinal cord injury? And we could also expand into ultra early surgery for spinal cord injury, but maybe just focus on lumbar drains now for spinal cord injury and where the evidence is for that.
That's a great question. I think they're still figuring out. It's pretty widely supported mean pressure of 85 millimeters of mercury in the first 5 days out. But most of the literature on the lumbar drains does come from the cardiovascular colleagues I've not seen a strong neurosurgical position on it, and I think that's definitely an area of interest. If we had animal models, perhaps porcine, that we could study better with an acute weight drop mechanism, we probably would have better and more robust data. I would love to see more real-time mechanism of injury studies before I have a stronger position personally. That being said, a lot of the animal models, porcine or rat, are limited because they can't one-to-one reproduce the mechanisms we see in humans. Many people are presenting delayed, or there's an ongoing compression or some sort of mechanism that prevents the immediate release of the primary injury. And hence, in the animal models, we have a quick mechanism that we can't translate to ongoing human mechanism. So that's a long answer to your question, but in my practice, I will augment mean arterial pressure in the first 5 days minimum for spinal cord injury, but I do not employ lumbar drainage. If I think there's significant extrinsic compression ongoing, even in the acute period, if there's neurogenic shock, that likely is an operative case for me to decompress and or stabilize.